Welcome. You should all see my screen now. We're going to be conducting this like a meeting, not a webinar, in the sense that all of you who have joined us should please feel free to put on your cameras, because when we take questions from the audience, you're welcome to submit them to me or to show up on camera and ask your question directly. But welcome. This is our third 2023 educational webinar series. The focus today is, what do healthcare providers know, or what should they know about diagnostics? An area that I'm going to say has great potential, but we are certainly not where we need to be today. So a little bit of opinion as we start off today. I am pleased to say that this webinar series may be live streamed or not, but photographed or recorded. So be cautious and understand that you are a part of the system here, but it is indeed being recorded. This series, as I mentioned, is part of a partnership with the Arizona State University College of Health Solutions, in particular the biomedical diagnostics program, as well as Thermo Fisher Scientific. So welcome, and we are very pleased about our partnership with Thermo Fisher. So my name is Mara Aspinall. I'm professor of practice in the College of Health Solutions, but today is really about our terrific speakers. We're going to be focused on what do healthcare providers know, what should they know, and what kind of solutions should we be talking about as an industry for the future. And that is the core today. We have three fantastic speakers. Our first speaker is Nathan Ledbauer. Nathan is professor and vice chair of pathology at the Medical College of Wisconsin and has been a tremendous leader in the area of education, both within the industry and more broadly. And I'm going to introduce everybody briefly now and then go back and have them give more of their background. Tom Miller, managing partner of Grayberg Ventures, a successful venture capitalist, but tremendous experience in the field. He ran the global MRI business for Siemens and so much more direct experience. And then Stan Rose. And Stan Rose is also working as a venture capitalist now, looking at companies throughout the life sciences field. In addition, a tremendous operating background, CEO of Nimble Gym Systems. He has experience in both starting companies, which you'll hear about today and why, as well as selling companies. So very successful from the operational and the exit perspective. So with that, I'm going to turn it back. Nathan, why don't you start? And if you can introduce yourself, and then we'll kick off the panel.
So thanks very much, Mara, for the wonderful introduction. Thank you for inviting me to participate today. As you said, my name is Nate Ledbauer. I'm a practicing clinician, so I'm a professor and vice chair of pathology at the Medical College of Wisconsin. I spent about the first 16 years of my career running the clinical microbiology lab for Froedtert Health, which is a regional health network based out of Milwaukee, Wisconsin. Like so many others, COVID really was an opportunity, but it was also a significant drag. And so I've moved out of the microbiology laboratory into more of an administrative role, overseeing all laboratories for the health system. In addition to all of this, I get a chance to see and work with a lot of the new and novel diagnostic approaches through our research program, really getting the opportunity to start to think about how do these get placed within healthcare, and really what information do we need to be providing to our ordering providers around how to use these tests most appropriately. So thanks again for the wonderful invite.
Super. Well, it's great to have your experience from a variety of other places, but particularly in running a lab today. Tom?
Hi, Mara. Thanks again for having me. I am a medical physicist by background, but spent most of my life running companies, almost all in diagnostics, actually to 90% in diagnostics, from my own 12-person startup to a 26,000-person, 132-country organization at Siemens, also, Carl Zeiss and others. I think I've covered and launched products in almost every area of diagnostics at some point. Either it's medical imaging, in vitro diagnostics, pathology systems, diagnostics where you insert things into people's bodies or do other nasty things to folks in order to get a diagnostic result. I now find myself as a venture capitalist. I do not consider myself a financial guy, even though I can fake it. However, I do spend time now allocating capital to ideas in diagnostics because my firm invests only in diagnostic technologies that we think could ultimately be successful and most importantly beneficial for patients.
Super, Tom. Well, thank you. And vivo in vitro, we won't go into nasty things, but the idea of your breadth and depth of experience is tremendous. So it's great to have you here. Stan?
Hi, Mara, and everybody else. Good day. Thanks for inviting me, and looking forward to the conversation here. So let's see. I started my career actually as a biologist, turned genomics entrepreneur around the time when genomics became a thing. And over the last 30, 35 years, I've worked with a variety of scientists and clinicians to commercialize life science tools, diagnostics, therapeutics, that all in one way or another depended on DNA analysis, either in their development or their use. And this sort of goes back, I think, in the beginning. I had a great opportunity to work with PCR when it was a novel technology. I'll skip sort of everything in between, which there were some very exciting projects there. But most recently, I wound up in a situation where I was working on developing a diagnostic that impacted my own health as a patient. And that was due to the fact that I had a kidney transplant in 2011, and then subsequently realized that the standard of care for monitoring transplant recipients was actually not as good as it could be. And that led me to co-found and grow a company called Transplant Genomics, basically developing diagnostic tests to detect what's known as silent rejection in kidney transplant recipients. And that business wound up being acquired by Eurofins in 2019. And since then, I've sort of moved back into helping new companies get started through either advising, directing, investing, whatever seems to make sense. So that's my story.
Well, thank you, Stan, for sharing your personal story as well as your professional story. And I know that as part of our discussion today, we will hear much more about that. So let me open it up with a question. And to our audience members, please use the Q&A or use the chat, and preferably the Q&A, but get us your questions, get us your comments. We want to make this interactive. So let me start by opening it broadly, and I'll ask each of our panelists to talk about what is the problem today. How do diagnostics, how are they by treating physicians? And, fundamentally, I said at the beginning, I think there is a problem, but I'd love to hear each of your perspectives as to what that problem is. And then I want to talk about why it exists. Tom, do you want to start with you?
Sure. I think we're living in an age of abundance when it comes to diagnostics. I mean, there are more technologies that you can throw at a patient than anyone can possibly keep in their brains, which I think is primarily the problem. As I like to say it, since I'm an old guy, when I graduated from the graduate program here in Massachusetts, if you looked at the ICD system, there was about 1,900 diseases. And if you look at the last release, there's about 55,000. If you were an enterprising medical student in my day, you might be able to commit to memory most of those 1,900 diseases. Today, I'm going to tell you, you don't have a prayer. all of those things mean that, a physician has to have more things in their brain or has to know where to get information about what the test looks like. And more importantly, when you look at the mathematics of diagnostics, it means that ultimately the incidence of any one of those diseases has just gone down. Which means test performance, as you match them, has to correlate to that. And I'll just stop there and basically saying the physician today, confronted with the need to diagnose with increasingly greater specificity, since the treatments tend to be more and more specific with time, is quite challenged to try to select not only the right test at the right time, but the right test in the right time, sequenced in the right way in the course of treatment. I'll stop.
Well, there's a lot to unpack there, so we're going to come back to that. One comment I'll make, just to think about, is how do physicians have the right tools to do that? But Stan, I'm going to go to you, and again, from the quote business perspective, even though you've got the science too, and then Nathan from a lab perspective. Stan?
Yeah, sure. First of all, I agree with everything you said. I think on top of that, there's a real challenge for any physician right now to just stay up to date on new developments. So I'm sort of saying the same thing, but in a little different way. There's so many things to have to pay attention to that combining that with the day-to-day demands of of just caring for patients. It's just difficult to stay up to date on, anything new. And if you're not, there's a very small percentage of physicians who have active research programs where they're involved in developing diagnostics. And, in that group of physicians, tends to be very well informed about what's going on in their area of specialty. But if you get beyond that small group, it just becomes impossible for anyone to keep up on all the variety of developments that are going on, even though they try. And I think oftentimes, if you then sort of just think about the whole ecosystem of test development and reimbursement and regulation, it ultimately falls back on the companies developing the tests to really drive physician knowledge about those tests. And there are sort of conflicting powers at play here, because also at the same time, most physicians are, I think, reasonably skeptical about new developments and have a lot of incentive to pay attention to the current standard of care in their field. And societies that you'd love to have a statement from a society that some new diagnostic, makes sense to be used in certain situations. But again, inherently, the people within the society who know the most about those diagnostics are the people who were involved in developing them, who may have conflicts of interest. And there may be multiple groups that are developing independent solutions and have different opinions about which one is better. And so it just creates a very complicated environment for any physician to have to navigate through. I think that's one of the reasons that it's just so challenging for anyone to keep up on all the new developments. So I'll stop with my comments there.
No, that's great. And I'm going to ask about where are there industries or even geographic locations, as Professor Michael Donovan asked, that do it well, but we'll come back to that. But Nathan, give us your overview of the issue today.
So I think, quite honestly, as Tom and Stan both kind of highlighted, they referred specifically to physicians. I think one of the biggest changes that we've seen happen within medicine, and that's really challenged how we order testing, is we have a great diversity of different providers that might be ordering tests today. So you might have a nurse that might be placing an order for a test via a protocol order. You might have an APP, so a nurse practitioner or a physician assistant that has a very different level of education and subspecialty training from the classic physician that we think about, that might be ordering that test and choosing the test. And so we have to recognize that we have a lot of diversity now in who orders testing, and really trying to build decision support around that so that we recognize those differences in in ordering providers. The second thing I think that we have a problem, getting back to a little bit of Tom's comment, is we have a test stewardship issue. Too often we see test ordering basically kitchen sink style, if you will. I'm just going to order everything because I'm not 100% certain what to do. And as a result, oftentimes we get results that are confusing and are difficult to interpret. And the final thing I'll really say when it comes to test ordering, especially as we look at some of our more complicated tests, is, and I hate to get into this area, but I feel I need to touch on it a little bit, and that is what we consider to be an LDT today, which was typically supported by evidence coming from individual hospital laboratories, has shifted significantly. I've been in this field for 16 years. And 16 years ago, an LDT was maybe a PCR for flu off of a BAL, because that wasn't FDA cleared at the time. Today, we may be making important cancer diagnoses, prognostic decisions based upon an LDT where there may be very, very limited information available in the peer-reviewed literature to help make that decision. All the while, we're seeing a lot of direct marketing to patients who are now asking for test results. So again, coming back to the lab stewardship or the test stewardship issue. So I think it's really, a very multifactorial issue, as all of us have really illustrated.
Wow. Yeah, we might be here for hours. I promise we'll end on time, but there's a lot to talk about here. So let me ask, first question from Professor Donovan real quickly. Are there areas of either functional areas and disease states where it's done better, or geographic regions? And again, I'll start with you, Tom, because you have worked so much globally. We tend to focus on the US, but are there any areas that are doing it much better?
I tend to think, so let me separate that into two halves: medical subspecialty or discipline versus geography, right? Because those are two different
Absolutely
questions. In medical subspecialty or discipline, I think what's done fairly well are things in the acute cardiovascular space. I mean, if I look across at least the developed world at what happens if I show up in an ED with chest pain, that tends to go pretty well. Or if I show up in the ED with the thought that I might have a stroke, and now you have to exclude that it's hemorrhagic, and then you have to exclude that I might not be a candidate for RTPA, and you get it on time. More or less, that sort of goes fairly well compared to other areas like oncology, where I would say it's a nightmare. In terms of geography.
Tom, can I interrupt you for a minute? Two questions. Is it because it's acute and errors that are made there, really are life and death, as opposed to oncology, which, doesn't happen within hours? And is it because the pharmaceutical companies did a lot of great work in educating?
So I tend to believe, and I'd love to hear Nate's view on this, because I could be totally wrong, because I'm looking at it from one viewpoint. But from the viewpoint of industry, when I brought things to market in the cardiovascular area, the role of the societies in setting care guidelines was much stronger. I mean, it's like a fist, you're not in the guidelines, it's not going to get done. You're in the guidelines, it's going to get done. And so if you get a new cool thing, you're going to go work like hell to get in the guidelines. And it's hard, right? It's hard. You have to get a lot of evidence, and the one thing that's easy about it, however, is the sequelae to doing it wrong is fairly rapid. So the feedback loop is fast, right? So I actually think that's part of the reason. In many other of the medical disciplines, at least that I've seen, the role of standard of care guideline stewardship is much weaker. And there could be lots of reasons for that. And therefore, when I'm bringing, or one of our companies is bringing a test to market, there is much less of an emphasis on get this in the care guidelines, damn it.
Yeah.
Now, I could be totally wrong here. So as I said, I'd love to hear Nate's comment because I have one narrow view.
Nate, why don't you comment on that, and then we'll come back to you, Tom, on geography.
Okay.
No, I 100% agree with you, Tom. And I think the perfect example of this in the cardiovascular space is the ultrasensitive troponin test. I remember 15 years ago, ultrasensitive troponin was already starting to be sold. And it was, at least initially, a commercial failure because nobody knew what to do with it and it wasn't included as a part of the guidelines. It wasn't until we really had some of those well-designed studies that looked at the benefits of ultrasensitive troponin and that ultimately led to it being included in the guidelines, now is certainly standards of care, that it's become much more standardized. If we look at places, again, you cite oncology, I'll cite sepsis as another example. Oh, yeah. Sepsis is an area where we have so much variability and we result in really, quite honestly, bad outcomes to patients because we have a lack of standardized approaches and we have a lack of really good standardized tests to help us make those correct decisions. And again, all of that is going to ultimately be driven by inclusion in the guidelines and really helping providers to know what to do with it. I think the biggest area that quite honestly scares me about this is as we start to look at new prognostic tools to be used in the primary care environment, understanding what those tools tell us and how those tools should be used to an APP seeing primary care patients or a physician seeing primary care patients is going to be a huge challenge. And it's really an opportunity where we need better, more standardized guidelines.
Great. So we're going to park that, which is the idea of the guidelines and the professional associations playing a much bigger role. But Tom, let's go back to you in terms of where we are geographically. Are there any places of the world that do it much better?
So yes and no. Here's what I say about, I've lived in Europe for some time. I've spent a lot of time in Asia running the companies there, and I'm an American. And what I like to say to people who ask me about different healthcare systems is that if I'm normally sick with a normal thing, I would want to be in Europe. If I'm really sick with something difficult, I want to be a wealthy American. And that tells you almost everything you need to know about how diagnostics happen. Because if you're, as I lived in Germany for quite some time, and it would be amazing if, kid had a problem and some symptoms, they would get a routine workup. They would get the same routine workup in a big city as a small rural center. It would get paid for, and you would simply do it. And in the United States, the difference between the fairly wealthy town I sit in right now and 20 miles in that direction may be day and night. So I tend to be a socialist venture capitalist, which is an oxymoron, but it means that for the great majority of healthcare, I actually like systems that sort of try to treat everyone somewhat in the same way. And those folks, for the majority of cases, more often get it right.
I love that. We're going to come back to that with the role of AI to help create those systems. But first, Stan, any focus areas within the discipline or geographic that you want to talk about that do it well or particularly not well?
Yeah, I've sort of had the same personal experience, I guess, of being sick in, let's see, in Europe, in Asia, with something that wasn't all that complicated, and and the response was great. So, and I've more frequently had the experience of having this is all personal experience in the U.S. and it's, just as Tom described. So I don't have as much professional experience with diagnostics on a global basis. Most of my experience is in the US. So I'm not sure I can really comment on that.
And in the transplant arena, I mean, do you find that, I mean, that's a pretty niche area where
yeah,
it's not always acute. Are physicians better or worse able to handle diagnostics?
yeah, it's there are a lot of things that are really interesting about transplant. And now I'm going to speak about transplant in the US, but to the degree that I know about how it happens outside of the US, it's fairly similar. So first of all, the market's fairly concentrated. So there are a relatively small number of programs in the US. There's about 240 programs, and about half that number account for maybe 80% of the transplants that occur. So there's a relatively small number of groups. Within them, within each practice, they have their own standard of care. There actually are very few society guidelines. It would be great if there were more. I believe some of the challenges in getting more of those are, I think one of the biggest challenges is data, and again, this is a sort of an issue that's peculiar to, well, it's peculiar to transplant, but not just to transplant, to any disease that affects a relatively, or any health condition that affects a relatively small number of people. So this isn't like reproductive health or oncology, or the number of patients that are addressed in any given year is much smaller. And as I said a moment ago, the number of programs that are involved are smaller. So it's a lot harder to conduct large-scale studies to really prove your point about utility of a novel diagnostic. It doesn't make it any less important, but it's a lot more challenging. And so you just don't find large numbers of publications of large-scale studies that a society can point to and everyone can reach agreement that this is the way it ought to be done. And then you add on top of that within this relatively small group of programs, they virtually all have research programs going on, so they're competing interests. So, I think it's an area where it's hard to get the society to make a statement regarding standard of care. But having said that, there are certain things that that are done by everybody. Now, some of those may be very, very old. There are, but if you look at sort of how, for example, how are patients cared for early on post-transplant, there are a couple of, there's not one uniform way, although there's some small variations. And that applies to the diagnostic tests that are then applied, because quite frankly, post-transplant patients are subjected to an enormous amount of diagnostic testing. I'm literally, for the first month, a patient is tested 3 times a week for, all of the standard, metabolic markers, CBC, and then a number of viruses that could come up because these patients are significantly immunocompromised. So there's a lot of testing that goes on. There's probably, I don't call it over testing, it's necessary. And then that backs off over the next several months, but there's a lot of testing that goes on, and that's all fairly uniform and generally agreed upon. As you get out longer term, get up, past 18 months post-transplant, that's where you see a lot of variation occurring, both in the frequency of testing, what people test for, and then the application of novel diagnostics. And over the last decade, there's been a lot of activity, in particular related to various biomarkers that would give an indication of early signs of rejection. There's not great consensus around what to do. And in fact, that's actually there's an open comment period right now on the whole notion of whether or not more than one type of test should be used in this period. And, my opinion is a little bit misguided because the tests actually generate different and complementary information, but that's a whole other story. So I'm just trying to give a flavor, for how complicated things are in this one little niche area.
So that's a great context, as you say, for a little but critical niche area. And you brought up a number of points, and I'm going to go to Professor Travis Schlappe after this, who has a question. But I'm going to set it up because, Stan, you spoke about, and Tom, everybody spoke about the importance of evidence and the importance of this information. My broad question, and Travis will follow up on it, is there a higher standard for diagnostics? And I'll say for publications, there seems to be, or at least a different standard that makes it harder to get into New England Journal because they're looking for double-blind clinical trials, which we don't do. And therefore, the first check mark of having something published in some of the top publications is an X. So how does that work with professional societies? So Travis, I didn't mean to take some of your question away, but can you follow up? What are you thinking about in terms of how the professional societies work?
Yeah, my question, somewhere, is there a system for applying to get into the guidelines, or is it just kind of random and you do a good study, you probably don't get into New England Journal, maybe some other journal, and you hope that they notice and put you in the guidelines? The FDA has a nice clean process where you submit, you wait your time, and then you may get pre-market approval. How do these societies work?
So Nathan, do you want to start there, or Tom?
Sure, I can kind of start with that. So the answer, Travis, is it quite honestly depends. So if you look at one example of where it's a bit more systematic in terms of what studies need to be done, it's probably the antimicrobial susceptibility testing space. So there's a very clear group that gets a lot of feedback at annual meetings, and the group together says, we want to look at this question. This is the data we need to be able to look at it. And they'll actually go so far as to draft people that can, or draft companies that can help provide that kind of data to start to answer that question. So at least in the antimicrobial susceptibility testing space, there is it's a pretty well-defined process in terms of how do you get into the guideline, and then if you want to change your breakpoint, what data is needed in order to do that. For so many of the other guidelines that are out there, it's not that clear. So it typically starts with a literature review, what's been published in the literature, and then we start to look at, okay, based on this is what's available in the literature, these are the experts' opinions, and all of them then start to get weighted in the evidence in the guideline, and we start to get drafting closer and closer to a guideline. So in most of those cases, it's a little bit more ad hoc. Now, a lot of times companies will say, okay, our KOLs are telling us that we need X, Y, and Z information. We need these outcome studies to be done. We need these health economic studies to be done. Typically, a lot of those KOLs also sit on guideline writing groups. And so they can kind of direct companies where things need to go in terms of what evidence is needed. But really, it is a lot of variability.
Tom?
Yeah, I couldn't agree more. I would love to say that all of the professional societies have uniform processes. It's the furthest from the truth. And not only that, if you read the guidelines, you'll often find that there are recommendations for standard of care. Then there'll be a whole laundry list of things for which there are decreasing amounts of evidence that it should be useful or not. And it's left up to the reader, right? So I think Nate summarized that perfectly. I would use the opportunity to address your question, Mara, which is, what about the need for evidence in diagnostics? Are we diagnostic folks held to an unrealistic standard? I often think that when I'm doing my day job, but if I put my hat on as a potential patient, then I say, well, maybe not. And the real problem is that if you want to do a prospective, double-blinded trial with a sufficient follow-up period to know that your false positives or false negatives were truly false positives and false negatives, those are damn expensive. And the difficulty is that diagnostics don't get treated the same way financially, and therefore it's harder to cover that expense. So it means like folks like us, which place financial bets on diagnostics, we got to be either really good or really lucky, or we're in trouble. But I think it is necessary, especially when the sequelae of the test may be affecting the patient's life.
Yeah.
Then damn it, if I'm a patient, I want to see a prospective double-blinded trial.
I agree, Tom, but let me, I'll use the moderator's prerogative here. I'd love others to comment on it. Is we get criticized in the diagnostics industry for a test that might be 90% specific and 90% sensitive, that it's not good enough for a lot of the reasons you just said. However, and the most expensive test now is maybe, let's forget imaging studies, but other than that, an IVD or LDT is $7,000-8,000. We get criticized for that 90-90 test when you have drugs that work 50% of the time, and there are virtually no drugs, certainly branded drugs in the first few years that are less than 25,000. I mean, they're individual, but much more expensive. How do you make how do you find peace with that?
You and I have had this discussion more than once, so we can complete each other's sentences here. But in my view, the problem lies less with what we're doing in diagnostics and more what we're doing in therapies. In other words, my view is that the number of therapies that sort of get out the gate without a companion diagnostic that allows you to rule in, that's the crime. And in truth, you could probably cut expenditures. There's nothing worse you can do for a patient than to treat them for a disease they don't have with a therapy that's going to be ineffective or potentially harmful, right? So if there's a diagnostic test that allows you to prevent that, you save the healthcare system a ton of money, you save the patient a lot of potentially mortality or morbidity, and you're in good shape. So I agree with you. I complain the same way you do. I'm just not quite sure my fix is the same.
But Tom,
Okay.
if I can
Please,
just add
Nate.
one thing.
Yeah, Nathan.
Yeah, the one thing I want to add to that is we have to, before we can break that down, we have to break down the silos of the healthcare system, because healthcare systems today are way
That's
too
easy.
siloed.
No, sorry, I interrupted you, Nathan, with a snarky comment there, but please.
I was going to wait for you to tell me how easy it was, Mara, and how I could do it. But this is a huge problem today, and we have to solve that part of the problem as well in order to use that, in order to use those tests, because until we do, it's my budget if it's a lab test, and if, I have to meet my budget, I'm obligated to meet my budget. And so we have to break that down and start thinking about it in the context of I'm managing the whole care of this patient and not just one aspect of that care.
So let's hold on that point. Tracy Petros, I don't know if you're online and want to come on camera to ask your question about the Preventative Services Task Force. How, on the idea that we don't want to leave it as it is today, because I think we all agree it's not ideal. How can we improve? Tracy, do you want to come on camera? Do you want me to ask your question?
Hello, good morning. So my question was related to the United States Preventive Services Task Force. At least that is one of the guidelines that I believe most practitioners do incorporate when the society guidelines may be weaker, they compare it. What process or has diagnostics been able to approach that body? And is that something that is an objective and goal to be able to get on those? So at least the societies can see the recommendations and possibly change or incorporate the new diagnostics into their society guidelines. Thank you.
Thank you. Thank you, Tracy. It was a little bit hard to hear, but I hope everyone saw it or saw the question in the chat about what is the role as the U.S. Preventative Task Force. And obviously, we've heard a lot. We did our last seminar on this about mammogram timing and otherwise. But for, I'll call it standard diagnostics that are used more frequently, not just screening, can that play a role? Can that organization play a role? Or bringing in Elizabeth's question, which says which organization should play a role? So we can go from at least somewhat from the top down, and we'll come back to the bottom up. Who wants to start? Nathan?
Sure, I can certainly take a stab at it. I think, can the U.S. Preventative Services Task Force play a role? Absolutely. And we've seen them be relatively responsive to things like mammogram screening or HPV testing or cervical cancer screening. And so even in colorectal cancer screening, we've seen them be very responsive. The challenge with the U.S. Preventative Services Task Force, quite bluntly, is the time. We are having these new diagnostics be developed at lightning fast paces. And if you look at, and again, I'm just going to pick cervical cancer screening, the rest of the world shifted to a primary nucleic acid screen anywhere between 8 and 10 years ago. And we're only now in soon to be approaching 2024, starting to have that discussion about moving to an HPV primary screen. And a lot of the discussion is still centered around, well, who do we miss and who do we not miss? And so while I appreciate the level of diligence and the level of evidence that they're requiring in order to make those guidelines, it is a little bit of a slow process. Similarly, with other federal agencies, we've seen them try to kind of step in and help support the guidelines. Unfortunately, it tends to be almost a bit too slow. So I do think, and I like the fact that the societies, those that are very actively engaged, oftentimes have the experts that are needed to make these guidelines. Again, I think a society that does a very good job with guidelines is IDSA. I think NCI, through some of the cancer guidelines, are really trying to move in that direction. I just think we need these guidelines to be a bit more comprehensive. And I'll certainly let Tom and Stan kind of throw their opinions in too on that.
Dan, you want to start?
Yeah, I probably have the least experience on this one, but
Stan,
yeah, I don't.
Let me ask it this way. Would it help? I know you're doing more than transplant, but I'll focus on that area. Are there enough national guidelines in the transplant area today?
No.
Yeah.
But I think it goes back to the societies. If the societies aren't, there's sort of two major societies in transplant. Well, in renal transplant, but let's say there's 4 societies in transplant, more broadly speaking. If they don't have consensus, then it's difficult to have the U.S. Preventative Services Task Force take any position, until the societies have taken a position first. So, I think, when there's broad recognition among the appropriate group of professionals, then I think it's extremely helpful to have the federal government take a position on it. But when there isn't, I just don't see how they do it. How the government takes a position on, that's really helpful.
Yeah. Tom, anything to add to this part?
Yeah. My worry is that it's not a solution to every kind of problem, right? So the problems that Nate mentioned things like cervical cancer screening, mammography screening, et cetera. I mean, there they play a great role, and a good, powerful, strong, yay, get it done role. Because there's already enough debate about who you include and who you don't include in those groups to be tested. But due to the problems created by people like Stan, where he's innovating all these new genetic tests, which are being innovated at a rate that's just at breakneck speed. And now you want to know that this test, which could be critical for a patient's treatment selection, is available. And by the way, it's only been out on the market for 4 months. But by the way, the evidence has been amazing, and amazing for this very tiny, narrow group of patients. Man, you cannot wait for a big guideline group like this to respond. So I think you have to sort of almost split up the kinds of problems that you want a big government organization to help deal with, and ones that you need to have narrow groups of experts that really are on top of what happened 6 months ago to be doing. And I don't think it's a one-size-fits-all approach, unfortunately.
Yeah.
Stan, I'm sorry to blame you for the entire problems created by the world of diagnostics today.
No, actually, one of the things that this reminds me of that's I think been very helpful in in getting some of these novel and powerful genetic tests used more broadly. It's not just the genetic tests, but any of the tests that are based on nucleic acid analysis, is finding when you have that situation where 3 or 4 months out, the initial data is just extremely compelling. So finding a group of thought leaders that you can bring together to work on a collaborative study, and then begin using the test in the context of a study that's ultimately intended for publication. That's something that's very attractive to most physicians who are involved in any of these sort of relatively small specialty areas, is the opportunity to first of all, to employ a novel diagnostic in the context of a study, and ultimately lead to a publication that will show whether or not it will have broader utility, especially when the prior data is highly suggestive that it will. That's a great way to begin to get a novel diagnostic used more broadly, and sort of lay the groundwork for ultimately going to the relevant professional society and advocating for them taking a policy position, because that's, in my experience, that's actually the way it happens. It's not that the society is out there ahead of time thinking about areas in which we should make recommendations. They're moving in response to people who are advocates, whether they're patients. Actually, they're generally combinations of patients or foundations that have supported research on various diseases or conditions, and physicians. So,
Mara, can I make just one quick comment here? I think there is a role for the FDA to play in a stronger way than they are today. And I'll just tell a very short story to tell this. So there's a company that, a pharmaceutical company that just failed in a clinical trial. And I'll round the numbers to make it easy. 50% of the patients that received their medication didn't respond at all. 30% got dramatically worse. 20% got dramatically better. And they failed. They came to a little company of ours, and we are able to identify that 20% almost perfectly. Now, the interesting thing is, they waited till it failed. They waited till it failed. And if those numbers were slightly different, or if, for example, the number of patients that it made worse didn't go as helped, they might have succeeded. So in other words, there I think is a role for the FDA to get a little tougher about the companion diagnostic need for rule-ins. And that I think would be a terrific amount of progress in the society.
I think that's a great point about rule-ins versus rule-outs, which is always kind of key to a diagnostic, to a company understanding where to do a diagnostic. I can't believe we're actually at less than 10 minutes left here. So I'm going to bring up kind of a lightning round. But Martin Ramirez and Nan Doyle have been having a conversation. Yeah, thanks for putting everybody on the screen. Martin Ramirez and Nan Doyle are having a conversation in the chat. So either or both of you can come up, but what it's all about is physician fatigue and decision fatigue and the challenge of doing this. I'm going to add, particularly when they haven't learned it in medical school. So Martin, Nan, your quick comments. I see Tracy nodding there. Give us your perspective and question, and we'll do a quick round of our panelists.
So some of you who know me, excuse me, my voice, I'm a little bit hoarse. Not a zebra, I'm a horse. Know that my background is both in AI and cognitive science, because I had two advisors during my PhD, and they both kind of did battle on a weekly basis as to which one, which is the right answer. And, what I've seen evolve over the past 33 years is the fact that we're seeing, because of precision medicine, because that's successful, thanks to Mara and everybody else who made it successful, now we have more diseases, we have more diagnostics, we have more of everything. The problem is that the human mind does not follow Moore's law, right? Our capacity does not double at all.
Yep. So that brings up the idea, and Nan, you're thinking about it for rare disease. Can AI play a role here?
Right.
Nan? You're still on mute.
You'd think I'd know. I think I'd learn after 4 years. Selectively, yes. I was just having this conversation. And hi, everybody. Nan Doyle. I've worked for years kind of at the intersection of genetic diagnosis and what we can do about it with gene therapy and other gene-based treatments. As Mara knows, I have a passion for rare diseases and getting them diagnosed sooner. Yes, I think there's a role for AI, but selectively. The catch that I hear over and over is that we try to use AI on data sets that are already small. And I ask this of every AI provider that I talk to, is your validation data set a subset of your training set, or is it essentially pulling out of the same thing? You're kind of layering paint on top of paint, and not getting rid of some of the inherent uncertainties and biases that come with that. That said, going back to the comment that I made in the chat, there was as much rhetorical as anything else. I've never been able to figure out why we devalue diagnosis in the genetic space and don't reimburse it as well or as quickly as we can. Yeah. We've got some competing phenomena going on of a doc wanting to order everything in the books just because they can, reimbursement rates being very low and then questioned, and pre-authorizations and blah, blah, blah. Here's the poor patient still bouncing from specialist to specialist in rare syndromically, not getting any further and costing the system money in the process. There's a lot to unpack there, and I've really enjoyed this panel to try to tease it out.
Thank you. So on the idea of going around, real briefly, this went by incredibly quickly. Let me ask each of you, role of AI, do you see that helping or hurting? And what one thing would you do to improve education around diagnostics? I don't like talking about 20 years from now, because who knows what we're doing. I'm going to say in the next 3 to 5 years, so we have short-term impact. Nathan?
I mean, is AI going to play a role in helping us to recognize rare genetic diseases or rare diseases in general?
Or even any disease?
Absolutely, unquestionably. It's going to play a role, and it's going to help us a great deal. I do want to say, though, there is significant opportunity in tools that are well validated, have a lot of potential to be used today, and that is decision support. We don't use nearly enough decision support today. to help people to recognize diseases and to order the right tests and to ask them questions. Instead, we ask them to pick a test out of a list of 10 other tests that look almost identical. Instead, we really need to be saying in clinical terms that our providers will understand and our providers will find useful. We need to be asking, what is the question that you're trying to address? And the way we can do that is through decision support. So I think decision support can significantly improve, and that can be done today and should be done in a much more standardized method, considering 50, 60, 70% of US healthcare information is controlled by one of two companies. This is not hard to do.
Okay, Stan, and then Tom.
Yeah, I totally agree regarding decision support. And, and I think it's, quite frankly, depending on how you define AI, there can be one and the same. So, I also see a number of positive, impactful roles for AI in helping physicians wade through this tremendous amount of information, but also figuring out, which of many potential tests ought to be used in a given situation. Especially with tests that are widely used already. So I'll call that decision support, but I think AI can play a big role in facilitating better decision support.
Wonderful. Tom, over to you on both AI and what you do going forward. And well, I'll leave it at that, I'll wrap things up.
So quick thing. First, let me define terms. To me, decision support is algorithmic, whereas AI is something where I'm not quite sure what the algorithm is underneath. So decision support, big check mark, yes. And by the way, I think it is a primary way where you can improve decision-making of clinicians with respect to test ordering much better, faster. Big check mark. AI, I'm both a big fan and deeply concerned. And my big fan is that for narrowly defined problems where we understand the inputs, the data is quite solid, and you can make sure that there's boundaries around it. I love it. For the big AI problems, until some AI scientists can tell me how they deal with error propagation in their AI systems, I'm really frightened, because I was beat up when I was a grad student that if my experiments did not have proper error propagation calculations in them, my answer was 0 plus or minus infinity, and therefore it was meaningless. And I worry about that with respect to AI. I'll shut up now.
No, that is great. Well, no, it's a terrific way to end and talk about it. I'll add one thing that I think we've talked top down a lot. We need also bottom up. Medical schools, programs like the ASU School of Diagnostics, as well as CME credits. I'd like to see personally that continuing medical education will require education based on diagnostics, not just other pieces of the field, that we have something specific on CME. So with that, as we talk about CME and education, I will summarize by saying, continue to join us, continue to be part of the ASU Biomedical Diagnostics community. Our annual summit for 23 just finished, but put 24 on your calendar, in person and over Zoom. Please join us in Phoenix for that. Biomedical diagnostics is an important part of the College of Health Solutions. These are the variety of our programs. And if you want more information, I have you two lists here. On the top are 3 great speakers. Thank you, Nathan, Tom, and Stan. Great conversation. Thank you for the participatory audience. And then if you want to hear more about the program itself, Michael, and Travis's emails are at the bottom. Thank you very much for participating here. Several of you were on all of the webinars as part of our series with Thermo Fisher Scientific. Thank you for that. We look forward to continuing to engage. If you haven't had a chance and you want to be contacted, put your email in the chat and we will continue to work with you. Stay well out there. Take care.
Bye.